All right, so we'll start with the case. 65-year-old man, history of diabetic nephropathy, currently on peritoneal dialysis. Presents with the ER with abdominal pain. He's hemodynamically stable and afebrile. So testing of the effluent peritoneal fluid shows cloudy fluid and the following: cell count of 960 and 95% PMNs, the gram stain pending. What is the best next step in care? I'll give you guys 10 to 20 seconds to think about it. All right, so the right answer is start intraperitoneal vanc and ceftazidime. So we'll talk a little bit about this. So we're talking about peritoneal dialysis-related peritonitis. So in terms of the etiology, it's kind of two main groups to think about. One is PD-related. So think about touch contamination. So people not accessing their catheter with in a sterile fashion, contaminating with skin flora. Or people can get an exit site infection, which is basically a cellulitis around the exit of the catheter, or a tunnel site infection. And those we're thinking about skin flora that then go into the peritoneum. You can also have a secondary peritonitis. So this is an intra-abdominal pathology, whether it's a GI infection or the translocation from constipation, a vaginal procedure causing the peritoneal fluid to get infected. So you're thinking more about GI flora. It's rare to have hematogenous spread, but it's documented. And if you're getting polymicrobial culture results, that's when you should be suspecting a secondary peritonitis. So pathogens are almost entirely bacterial. Fungal is rare, but is a lot more serious and often occurs in the setting of patients on antibiotics. We're talking mostly gram-positive pathogens, but again, you can get some gram-negatives when it's an intra-abdominal process, with coag-negative staph the most common pathogen isolated. So the diagnosis is this is different than SVP. So you need two of the following. So one is clinical features that are consistent, and abdominal pain or cloudy effluent are the most common findings for patients with peritonitis in this setting. Fever is less common, but can be found in patients. And the next one is the peritoneal fluid. You only need 100 white cells. This is different than SVP and over 50% PMNs. The fluid has to be in there at least 2 hours. If you think about it and you put the fluid in and pull it out right away, it's probably not going to look very abnormal. So you need to make sure you have a dwell time of at least 2 hours of the fluid you're testing. And then the third criteria is a positive culture, and we get much higher hit rates for culture positivity than an SVP. So more on the fluid analysis, it's good to inoculate at bedside. And again, if you have a short dwell time, you're going to get a false negative result. So you need at least 2 hours. Common hit rates on the culture positivity. We talked about the polymicrobial culture indicating a likely intra-abdominal process that could be secondarily infecting the peritoneum. And you should not be accessing this. The patient or a trained nurse should be accessing the catheter, or you may not use sterile technique correctly. So treatment, this again is different. Often this can occur on the outpatient side. So for patients who are not septic, intraperitoneal antibiotics are preferred. Usually something for gram-positive pathogens, we use vanc because of high MRSA rates, and a third or fourth generation cephalosporin, depending on the concern for Pseudomonas. If patients are septic, you can start IV antibiotics initially, again, covering the same pathogens. The duration is 2 to 3 weeks. You only add antifungals if the gram stain shows yeast or fungus. Anything intraperitoneal needs to dwell for at least 6 hours. And then we're going to follow up a cell count in 2 to 3 days to make sure you're improving. And if they meet criteria, but the culture is negative, you just treat empirically for both gram-positive and gram-negative pathogens. You only remove catheter if someone has a fungal or Pseudomonas peritonitis, if it's a relapsing course or recurrent. If the catheter is infected and that's causing the peritonitis, it's another reason to remove it. But again, you'd be talking to surgeons or nephrology in this case. For prophylaxis, so for patients before to prevent bacterial infection, doing daily mupirocin around the exit site. Patients who are going to get a colonoscopy or invasive gynecologic procedure who get peritoneal dialysis need prophylaxis before those procedures. And then any patient on prolonged antibiotics should be on oral nystatin to prevent fungal peritonitis, which again is very unique to this population. So going through the high points, for causes, we're talking about catheter-related or touch contamination with skin flora or secondary peritonitis for enteric pathogens. The diagnosis is different than SBP, so 2 of 3 with at least a fluid dwell of 2 hours. So the lower fluid peritoneal count of 100 white cells, cloudy effluent or abdominal pain, or a positive culture, 2 of those 3. Treatment is ideally intraperitoneal unless they're septic. We're covering for gram positives and gram negatives with vancomycin and a 3rd or 4th generation cephalosporin. And lastly, for follow-up, repeating fluid studies in 72 hours to make sure they're improving. These patients need fungal prophylaxis with oral nystatin, and then you need to think about whether they need their catheter removed. Any questions?